Well, good afternoon, everyone. My name is Chanel Whitaker. I'm Director of Education and Training with the Peter Lamy Center on Drug Therapy and Aging. On behalf of the entire team, we would like to welcome you to the Restoring Connections for Older Adults, Leveraging Community Services to Combat Social Isolation webinar. And as we prepared for this program, I thought a lot about my now deceased grandmother. And for almost 50 years of her life, my grandmother raised 14 children. And you heard me right, 14. And we all called her Mama. By the time Mama was in her 70s, my mom, aunts, and uncles were scattered throughout New York City, save for one daughter who stayed home to help her, but she also worked a full-time day job. Mama was very active in her church community throughout her life, but as her arthritis worsened, she frequented the church less and less, mostly only leaving the house for doctor's appointments. And although there were always family members coming, going, and calling on most days of the last 15 years of her life, she spent them at home alone with, of course, Oprah to keep her company every afternoon at 4 p.m. And I don't know if she felt isolated or lonely, but I do know now that she was at risk. And I imagine that each of you could share many stories of family, clients, and patients who are at increased risk of social isolation and loneliness. So during today's program, we look forward to sharing very practical strategies for how to better identify older adults at increased risk of social isolation, to share some of the best practice models of how we can better connect with older adults and increase their access to vital community partners and services. And in the end, we hope that everyone represented on this call will be able to identify at least one strategy or one new connection that they can make as a result of this program to better support the older adults that they serve. Several members of the Lamy team collaborated to develop this program, including members of our executive team and the Lamy Champion Coalition. The Lamy Champion Coalition is a diverse group of clinicians, educators, researchers, and community stakeholders committed to improving the health and well-being of older adults. And it is through discussions with the Lamy champions that this Lunch with Lamy series was born, to really talk about how the broad care team, from healthcare professionals to community advocates, can work together to find solutions that challenges that impact older adults across the spectrum of care. To learn more about the center, coalition, and upcoming events, please visit our website by clicking on Meet Our Team. And now let's welcome our esteemed speakers who are here with us today. And they'll share more with us about their work during the discussion, but I'd just like to give an early welcome, and you will find their full bios at the end of the slide deck. So I would like to welcome Linda Stewart. She is the Caregiver Program Manager at Johns Hopkins Bayview Medical Center. I would like to welcome Kim Burton. She is an advocate, educator, and with the Mental Health Association of Maryland. I would like to welcome Tricia Cash. She's a Frederick Health Network clinical pharmacist with Frederick Health. Welcome to Kim McCormick. She is a Frederick Health Network care coordinator with Frederick Health. And finally, and she will actually be our first speaker of the afternoon, Marina Nellius. She's a community social worker with the MedStar House Call program. So welcome to our faculty. And lastly, but certainly not least, welcome to you. It is evident from our attendee list, we actually looked at it as of yesterday, there are likely more here today, but it's evident from the people who have registered that you are really representing the full spectrum of older adult care services, both health professionals in health systems out in the community. So we're really excited to have you here today and look forward to hearing your feedback on how we can better serve older adults who are at risk of social isolation. And with that, I welcome Marina, and she will talk about social isolation and the risks and recommendations for the patient care team. Marina?
Hi, everyone. Thanks, Janelle. So I am really honored and excited to be here today to speak to you. I am going to start with an overview, highlight some risks, and then end with recommendations for your practice. So next slide. So to ground us, I wanted to reflect on Baltimore. As I describe it, a tale of two cities that's plagued with health disparities. There's two neighborhoods in Baltimore that directly highlights that the city block you live in does impact your life expectancy by 20 years. In the Bel Air Edison neighborhood, which is in the east side of Baltimore, the life expectancy is 66.9 years. In the same city, in the Cheswold neighborhood, which is northwest of Mount Washington, residents have a life expectancy of 87.1 years. Less than 9 miles away in the same city, an almost 20-year difference. But how does this happen and what leads to health disparities? Next slide. Well, what leads to health disparities, those are social determinants of health. And social determinants of health are the conditions in one environment where we work, live, and play, and age that directly impacts our functioning, our quality of life, and health outcomes and risks. So I want to pause here for a little moment because I want us to focus on some examples of how social determinants of health directly impacts our health itself. So here you can see the arrows. So it's a little bit confusing because it looks like it's on housing, but I wanted to focus on what if you lived in a neighborhood that had unreliable transportation or inconsistent public transportation? And at the same time, you also lived in part of 24% part of the Baltimore, which is considered a health priority area, also known as a food desert. So I want to reiterate that again, 25%, almost a quarter of Baltimore City is considered a healthy food priority area, also known as the food desert. And then the next one, which is then that arrow, which is a safety. So what happens if you live in a neighborhood that is plagued with community violence? You're at greater risk of injury and death, but not only that, also of implications of PTSD and other mental health implications. Next click. And what happens if you lack social relations? So let's focusing on those arrows, social integration with support systems and community engagement. We need social relationships because they really do provide us influencing our behavioral norms, especially the healthy ones. So to provide a real world example of this, let's think about smoking. And smoking we know is bad for your health. Well, studies time and time and again are demonstrating that smoking is actually considered more socially acceptable and of lesser concern to those that live in lower socioeconomic neighborhoods. So we wouldn't be surprised then that studies also demonstrate that there's a higher prevalence of smoking also in these neighborhoods. So we're not surprised then time and time and again that we see that healthy, positive, engaging, healthy relationships really do lead to healthy, positive outcomes. So now that we have a foundation of health disparities and also the role of social determinants of health, let's dig a little bit deeper, staying with the social relationships and focusing now on social isolation and loneliness. So next slide. So there's no age barrier related to social isolation or loneliness. However, individuals that are over the age of 65 are of high risk. And within this population, there's even a subgroup that those in the LGBTQ and minority groups, specifically first-generation immigrants, are the highest risk. And the CDC does consider social isolation and loneliness to be of most serious public health risk. So what is social isolation and loneliness? We oftentimes see them together, but they're actually quite different. Social isolation refers to the complete or near complete lack of contact with society. It relates to a quantifiable number of relationships that one has, so thinking like you can count them on your fingers. So it's quantifiable, it's a number. Loneliness is different. Loneliness is a subjective feeling of being alone. And it's the distress, and I like this definition, it's the distress that results from the discrepancy related to the perceived and ideal social relationships. Some myths about loneliness that you may hold or have heard on your own is that it's a normal part of aging, it's synonymous with depression. If you have a group of friends or you live with roommates, you're not going to be lonely. If it doesn't exist within married couples, and it'll go away if you just join a social group. Next slide. So I'm going to start highlighting a couple research studies that I really thought was quite relevant to our topic today. And this one, while it's from 2012, it really is one of the first studies that in a nationally representative population that examined the relationship between loneliness and functional decline and death. There's 3 questions that they use based off the UCLA loneliness scale. So the first question is, how often do you feel that you lack companionship? How often do you feel left out? And how often do you feel isolated from others? Nearly 1 in 3 subjects reported feeling lonely, and there was an association found between loneliness and disability, and death was quite strong. So I'm going to stay with the next slide. I want to stay with the same research study because I wanted to highlight certain aspects that came out. And we're going to focus on the 2 arrows. We have a blue arrow that's going to pop up and a yellow arrow. This is on the married individuals that were reported being married or partnered. So let's focus on that one first, the blue arrow. So individuals that identify, the subjects that identified as being married or partnered, you can see, I don't know if you guys can see this, but 62.5% of individuals reported being lonely, dispelling that one myth that we heard a little bit earlier. And then for those that are living alone, 26.7% reported feeling lonely. So the majority of individuals did not feel a sense of loneliness. The next slide. And this study, while it was published a year later, this one examined the association between social isolation, mortality, and the role of loneliness. The results were that social isolation had the strongest association with mortality, and loneliness did not. This means that while isolation and loneliness do really impact quality of life and well-being, efforts to reduce isolation would likely be much more relevant and more impactful. So really honing in on social isolation itself. Just to note, there were other studies that were completed after this time. And what I found and what I was looking in the research was saying that social isolation was also more attributed to health risk behaviors such as unhealthy diets, physical inactivity, and higher alcohol intake. And when the studies looked at loneliness alone, studies were somewhat ambiguous, and some found no significant difference for health risk behaviors. Next slide. So what is the role of the patient care team? Well, it's a big one. Nearly all adults interact with the healthcare system in some way. So for those that are lacking or without social connections, a doctor's appointment, a visit from a home health nurse or a case manager, social worker, or even an interaction with a pharmacist is maybe one of the few face-to-face encounters that that individual has. So providers and clinicians, what I always say is that we're in a very unique position to identify those that are at risk for loneliness and social isolation. And what I do for my practice and why I have them highlighted here is that I've incorporated the Lubin social isolation scale, and I also have incorporated the UCLA loneliness scale as well. These are important because not everyone is always going to be so open to sharing, hey, yeah, I'm feeling lonely or I'm feeling socially isolated. There's a lot of stigma that's going to be discussed a little bit further. But so incorporating one of these scales is really important to do in our practice. So next click to bring up the next bullet. So what do you do once you identify someone that is at risk for social isolation and loneliness? Well, if you aren't able to have a social worker or a mental health specialist already within your team, it's important to then refer those individuals to a mental health specialist or other community supports. And the good thing is that Kim Burton is going to be speaking a little bit more about what some other resources there are in the community. And one last note though, when considering economic disparities, there was a Denmark study that I found that individuals from the lower socioeconomic status had oftentimes, or from those neighborhoods, from deprived neighborhoods, had a higher prevalence of social isolation and loneliness. So once again, reiterating the importance of screening. Next slide. So what are the health effects? Well, there's worsening heart disease. We see there's higher prevalence of Alzheimer's disease, frailty and functional decline. There's poor sleep and depression. There's worsening control of diabetes. And as we can see here, there's increased mortality and higher healthcare costs. So in the end, I hope this very brief, very skimming the surface about social isolation and loneliness does demonstrate that really this is posing a significant public health risk. Thank you. And there's some references and resources if folks are interested.
Thank you so much, Marina. And now we'd like to welcome Kim McCormick and Tricia Cash. They'll share more on the Frederick Health Model and how they have been working on connections with older adults to combat social isolation.
Thank you, Chanel. This is Trisha Cash, and can we have the first slide, please? The next slide. Can you hear me? Oh, thank you. So Frederick County, Maryland, if you're not familiar with us, we have a population of about 260,000, with about 15% of those being over the age of 65 years of age. Frederick Health is the only hospital system in the county, and that provides for unique opportunities for community relationships and alliances. Frederick Health has about 269 licensed beds, also has a network of providers offering primary care, family medicine, and a wide range of specialty services. What I'd like to talk about today is the outpatient care management services, which are interdisciplinary and robust, with services including a care clinic, integrated care management, supportive and geriatric care, home health care, hospice, and transitional and chronic care management. Some care management services connect patients and clients with services to minimize isolation, but others provide these services directly. So the care clinic, just to highlight a couple of these very briefly, the care clinic is an interdisciplinary team, which includes a nurse practitioner, a pharmacist, social worker, community health workers, dietitians, and behavioral health specialists. The overall goal of the clinic is to help patients with understanding their treatment plan and their role in self-care. Social workers, behavioral health specialists, and community health workers specifically are integral parts of the team to identify and address isolation. These care clinic team members provide short-term services, including identifying the needs and assessing community services that may improve patients' well-being. The care clinic staff may visit patients in their homes, attend provider appointments with patients, assist with paperwork completion, provide counseling services, and assist with other ways in navigating through the health system. Frederick Health offers several self-management programs also to encourage patients in their healthcare journey, which not only educate patients, but also provide connection with others in the community. Another area on this system model that I wanted to point out is the integrated care management program. It provides care management services to primary care providers participating in the NDPCP program and population health. Care management staff are embedded in primary care practices and help in identifying isolation concerns of patients and assisting with connecting with services to address isolation. The care management staff in these primary care practices make up pharmacists, nurses, and social workers. And these services are similar to care clinic services, but specific to patients connected to the primary care practice themselves. As many other practices have, we have home health care services, hospice services, as well as supportive geriatric care. And Kim will be talking about our unique programs of transitional and chronic care management in a further slide. Next slide, please. So the interprofessional team, as Marina mentioned, all of us can be a part of identifying isolation, but sometimes helping identifying them and connecting them can be a real challenge. So I'm really feel blessed as a pharmacist to have social workers, behavioral health specialists, and community health workers to help with determining what avenues to take when we do identify folks with social isolation. Some other access points to other services. I've mentioned briefly the Living Well series, which are 6-week programs through the Stanford University that help patients not only learn about their condition, whether it be pain management, diabetes, hypertension, or just a general chronic care of their disease state, but also help in them reduce their potential for isolation. And also those access points to other services could either be Frederick Health resources, which we're talking about today, or community resources, which Kim Burton will be talking about later. Next slide, and now we'll go on to Kim McCormick to discuss our transitional and chronic care management program.
Thank you, Trish, and thank you for allowing us to be here today. We have a very unique program here at Frederick Health Hospital, the Transitional and Chronic Care Management Program. It was born out of the need to provide continued support for patients to effectively manage their chronic illnesses, such as heart failure, COPD, hypertension, and diabetes. It is funded by Frederick Health Hospital. It is a free service. We do not bill patients, insurance companies, Medicare, Medicaid. It is open to everyone, regardless of their situation. We are a tool and a support to promote health and manage these conditions. So this is the program. We place a Bluetooth tablet, a blood pressure cuff, pulse ox, and scale in the home that communicates with us at our office. They do not have to have an internet or any kind of connection in their home. We ask two things of the patient. We ask them to check their metrics at least once a day. And then secondly, we ask them to answer our phone calls when we call them. If they do not have a phone, we ask them to answer via the tablet. We call them when their metrics are abnormal with rechecking, or if they haven't rechecked, we ask them to recheck. We call them if they haven't performed the metrics in 2 days. We also call them once a week, irregardless, if their metrics are perfect. We call them to check in and ask, how are you? What's been going on? And do you have any concerns? Do you have any questions? Patients understand that this is not 911 or a life alert system, and we are not monitoring them actively 24/7, but they do understand we are monitoring from 8 to 4 every day, and that this is a tool and a teaching program for them to take by the reins. We receive our referrals from various sources: hospitals, doctors' offices, the Department of Social Services, friends, family, home health agencies, Meals on Wheels staff, senior center staff, neighbors. A phone call is all that is needed to get the ball rolling. We then contact the patient and explain the program. Of course, the decision is theirs whether they would like to participate. They have to agree. There's nothing binding, and they can stop at any time. And what have we learned? We have learned so much since the initiation of this program. We have learned through our hospital stat folks that the 30-day and 60-day readmission rates decrease significantly with these patients, which that translates into cost savings for the hospital system. Now, mind you, that was not the initial drive factor of this program, but however, because of this, the hospital has continued generously to support and allow the growing of this program. But we learned something much more significant and, in my opinion, important. We learned how important it is for human conversation and contact to make a program such as this work. Simply placing equipment in a home saying, take your vital signs, and if they're abnormal, call your doctor, call your nurse practitioner, just doesn't cut it. This is not a highly technical program. It is very basic, but it is human contact, kindness, very basic nursing care, and gentle guidance and compassion. It's the voice that says, what's going on? How are you? That's what makes this program work. The second program that we have is the medication management service. It's called Medication Management Program. We all know how difficult medication reconciliation can be for our older folks, and how can it not be? They often see various specialists. They have been in and out of hospitals, skilled nursing facilities. Drugs have 2 names. Am I on 2 beta blockers? I don't know. Sometimes the only thing prohibiting people from living safely, independently in their own place is their inability to manage their meds. We provide free weekly medication box fills. We reconcile their medications with their providers. We visit weekly. If they have difficulty remembering to even take their meds, we provide a reminder alarm. We make sure refills are ready for pickup, or if they're not able to pick them up, we arrange for a pharmacy that can deliver to them. We keep them independent and safe, and we provide that 30 to 40 minutes each week of human contact each week. Our stats folks again relayed to us that these people also had a significant decrease in their readmission rates. So it's a win-win once again. Our program, together with the services that Tricia explained previously, make this a success. It's a team effort. Through COVID, through this horrible COVID time, our med program did not miss a beat. We continued to visit, garbed up, masked up, gloved up, socially distanced. The human contact continued. And sometimes, honestly, we were the only contact the patient had. Our third program is a newer program. It's under our chronic care management. It's our companionship program. For these people who may need a little more one-on-one time, we give them 30 minutes a week with our medical assistant going out to see them. That 30 minutes, they can play cards, they can talk about their grandchildren, they can watch Jeopardy, they can do whatever they like. That's their 30 minutes. stay tuned for this program. We are hoping to find ways to make this program grow. Our program started with 30 patients. We now have 385 monitored patients, 105 med patients, and 6 companionship visit patients. If you take anything away from this, please take away this. I cannot stress this enough. The power of a 5-minute per week conversation, the power of human contact, the power of actively listening, truly listening when a patient tells you about the little things in their life. Please ask them about those little things. You can't imagine the difference that makes to them. Next slide, please. A new program that the hospital has embarked on with a member of the community is something called our Senior Service Grant Program. Its purpose is to assist in finding those seniors in the community who may have fallen through the cracks and not have been touched, assisted, or participating in any of the services the county or Frederick Health Hospital has to offer. The Housing Authority gives the program coordinator its referrals. The coordinator meets with the person and discusses any needs they may have. A nurse meets with them to assess any medical needs that may have gone unattended. And the community health worker then meets with them to sign them up for programs. The target is to have 100 patients enrolled in this. Currently, they have 46. It is a wonderful work in progress, and thus far it appears to be having a positive impact for those enrolled in it. I hope that gives everybody an insight as to what's going on in Frederick County. Next slide, please. This is just a referral form that we included for you. We just hope, like I said, we just need a phone call. This is a fine form, but we can always use a phone call, and we just hope that you learn something about what we do in Frederick County to help combat the loneliness. Thank you.
Wonderful. Thank you so much, Tricia and Kim, for sharing about this very robust model in Frederick, and we hope to learn more during the panel discussion. And now we will have Kim Burton, who will speak to us about some age-friendly community resources.
Thank you, Chanel. I would like to start by making this, bringing this home, bringing this a little bit closer to us and to think about the experience of loneliness. And so if you could go to the next slide. I would like for you to think for a minute about if you were feeling lonely, who would you admit this loneliness to? Who would you admit loneliness to? And you can type your answer in the chat box. And while you're doing that, I'm going to give a special thanks again to the Peter Lamy Center on Drug Therapy and Aging, and especially Chanel Whitaker, who's worked really hard to bring us all together today. And I'm seeing all kinds of responses from spouses to family members to moms to siblings and adult children. Therapist. Great. Can you go to the next slide, please? What I really wanted to do is us to dig into this idea of loneliness and what does it mean? And I want you to think about these different individuals and whether or not you would talk to loneliness, about loneliness with them. So an older family member versus a younger family member versus friends, close friends, spiritual leaders. And the reason I want you to think about this is because there is a lot of stigma. Can you do another click? Just another click. There's a lot of stigma around loneliness, and most people don't feel comfortable talking about loneliness because of the thought that it may say a message about them. So I know for me, at least, whenever I felt this way, it's like, what's wrong with me? And we need to turn that conversation around for people. It's not about what's wrong with us. It's everything about how satisfied we are with the types of connections and the quantity of connections and the quality of connections that we have with people in our lives, as Marina and others were talking. And I think maybe a silver lining of COVID was to give us all a little taste of what that might feel like, because we were restricted in so many ways. And fortunately, we've opened conversations around loneliness that didn't exist before. Can you go to the next slide, please? As a response to COVID-19 and concerns about social isolation and loneliness among older adults, a group of people, actually 23 different organizations and 4 academic institutions, were part of putting together some kind of a response. And what that response turned out to be was a volunteer call program where volunteers, 750 of them, were trained to make calls. And these were cold calls to Baltimore City residents who were older. About 11,000 connections were made, and these weren't necessarily all phone calls. They were all phone calls, but not necessarily all conversations. We left messages for people about the Baltimore Neighbors Network resource, but also ways to connect with other resources if they needed those. And what I really wanted to pull out of this slide was 2 big takeaways. The first one being that 66% of these folks that were called by volunteers who were strangers to them, 66% of those folks said that they would like a call back the following week. I think that's pretty amazing for that number of people to think, yeah, I really would like just to touch base with somebody. Please call me back next week. Another takeaway from this program was how resilient our older adults are. They showed enormous strength. Yes, they did want callbacks, but they also talked to their volunteer callers about their hope, about the fact that this too shall pass. They were in a place where they could gut it out. It wasn't ideal, but the world wasn't over for them. And I think this really tells us what we need to do is acknowledge and build on strengths of our older adults as we're talking to them. This is not about any kind of weakness. This is everything about just their ability to be connected with others. So if you can go to the next slide, I want to just tell you about 2 programs that were, here we go, Connections Project and the Next Project, Telephone Reassurance Program. These are both county-based calls. The first one is for Baltimore County. The second one is for Frederick County, where calls are made to older adults. Volunteers are trained to make these calls, and there's supervision involved. And these aren't by any means the only things that exist in Maryland. These are just the 2 I immediately pulled out because I know a lot about it. And actually, if you go to the Connections Project website, you will see other ways that Baltimore County, or I'm sorry, the Mental Health Association of Maryland is working in Baltimore County to try and keep older adults engaged. The Pro Bono Counseling Project has a warm line, and they beyond the warm line, they will provide licensed therapists, licensed clinicians to be supportive of older adults who may be experiencing anxiety and depression and a little bit more in need of mental health support. So I wanted to offer that up. And I also want you to know that Maryland Access Point, you can go to the next one. Hopefully you're all familiar with Maryland Access Point. But Maryland Access Point is the Aging and Disability Resource Center, and they exist in all jurisdictions of Maryland. And I would say that is the go-to place to find out what programs most locally exist that are available to help older adults with issues of isolation, with issues of loneliness, but also to connect them to fun programs. Increasingly, people are putting things online. So a lot of our senior centers have gone online. And while it was choppy in the beginning and difficult for a lot of folks, many older adults have really appreciated this opportunity to be able to participate online versus not participating at all. So the next one I wanted to pull out for you is Keswick's Wise and Well Center for Healthy Living, which has really great quality programs that are online. I want to back up to Maryland Access Point for a second, because I think it's important for you to know that a lot of the area agencies on aging are working hard to get technology into the hands of older adults who may not have technology, and also provide them with some IT support. The final bullet there I want to pull out is BDS Healthy Aging Networks. And this is, for those of you who've been around the city, you know, Betsy Simon. This is really a grassroots, very community-oriented effort by Betsy, who used to direct the Zeta Center for Healthy Living. This provides a weekly opportunity for people in the community to get together, to chat, to learn, and to focus on ways to stay healthy. So again, these are just some local programs. Now let me hit some that are more national. The AARP has a Friendly Voices program. This is free, and they will make outgoing calls to people who are in need of just having somebody to talk with. The next one is the Mental Health America. This is actually a website. They have a web page that talks about ways to create and keep and strengthen connections within any individual's network. It also gives people information about social networks and social network platforms. So I think that's a good resource. And then finally, the Friendship Line has been around since 1973. It's part of the Institute on Aging. It's a now a 24/7 call program, and its mission is really around suicide prevention. So all of their callers are trained very well in what older adults might need in terms of support. And it's more than a warm line. They also have crisis line and support programs such as elder abuse reporting, grief support groups, connections to information and referral services. Can you pull up the next, or just hit the next button? I wanted to read this blue call out together. The risk of social isolation is even greater for LGBT elders. LGBT older people are twice as likely to be single and live alone, and 4 times less likely to have children. These statistics are what drive the mission of SAGE USA, so that these elders have a community to lean on for friendship, support, and basic livelihood. So I wanted to say Friendship Line is great, but it's not a one size fits all. So what we should be doing is trying to find those resources that are most helpful and that most align with an individual's values and cultures and identity. And so we can find supportive programs that are specifically targeted to communities that need certain types of support. Mon Ami, the bottom bullet point there, is where I learned about some of these organizations, and Mon Ami will help any organization work on the technology so that they can scale programs and services to seniors. And then the Call Hub is a program of the Motion Picture and Television Fund that actually has a toolkit to help organizations set up a volunteer call program. So I would recommend people go to any of these resources if you want to learn more about making something like this happen in your area, or if you've got something going and you need help on moving it down the line and scaling it. Call Hub and Mon Ami are both good resources for that. So by we are not even touching all of the things that might be available for older adults. And I know that many of you out there are probably connected with programs that do have social support components to them. So I wanted you to please put in the chat box resources from your organizations or resources you're aware of that exist in your communities that might also play a role in helping with loneliness and getting support to older adults so that they feel part of the community and that they can expand on their network of people and places and communities that they can stay connected with. Hopefully the people are putting those in the chat. These obviously are not resources that we've been able to review, but we welcome you to look into them yourselves. Thanks.
Thank you so much, Kim, and all of our panelists for that information. You've really just done an outstanding job of outlining research, reasons why there is social isolation and loneliness and disparities in our community, models, as well as excellent resources. So I want to just thank the panel for outlining the information. So at this point, we're opening up this conversation to our audience, to our participants. We want to hear from you, and please, include your questions in the chat box. But as people are framing their questions and thinking about the whole challenge of how we help older adults in our community become more engaged, but not only working as healthcare providers and social workers, but looking at sustaining engagement and bringing older adults into conversations that we have. I wanted to start and ask the panel about the role of family members, because we as healthcare providers and staff people, we're here only for a while, but family members are with us all the time. So we really would like to know, what role can family members play in helping others with their social engagement and fostering their well-being, and what role we can play in training and supporting family members. So I might start with Kim and then ask the other panelists to give their thoughts.
My personal opinion is that a lot of family members feel responsible for the loneliness of their loved one, and we can help them understand that it is not the role of one family member to fully provide all the support that somebody might need. And then we also need to let our family members know what exists in the community. So however we can let them know that programs like yours do exist, the Call to Care program and other caregiver support programs, but also to know that Maryland Access Point is a good resource where they can find different kinds of programs that are available that might be interesting to their loved one. But I would also encourage family members not to be the deciders of what is going to make their loved one feel less lonely, because it's really the individual who assesses how much they value a particular connection. So they need to be part of that.
Thank you, Kim. Any of the other panelists who want to? Kim McCormick.
Thank you. A lot of times what we see in patients' homes is that they're so afraid of being a burden to their family. So they are so they're so hesitant to say, hey, I'm lonely, and so we try to forge that relationship with them and say, I think your family members would really want to know this, and they'd want to help you, and they're not, we try to be that mediator so that they do not feel that they can't tell them, or they don't want to put that burden onto their family members. And I think that as the clinicians and they reinforce that with them, that their family wants to help in any way possible, I think it would alleviate the burden they feel about admitting that.
Thank you, Kim. Any other panelists?
I was going to just bring up some experiences that I've had, is that oftentimes folks are very reluctant to get their family members involved as well. So it's just trying to identify, well, who is your social support system? Sometimes it's going to be the neighbor down the street that they have a relationship with, and perhaps it's not necessarily just the family members, but talking about the importance of expanding the social support system is really important. The other one, including an expansion of the support system and including them in it, is also the primary care physician. It's really important for folks to really develop rapport and have a really therapeutic alliance with their physician and having that communication. So I would oftentimes also refer folks, have these conversations, break the ground with the doctors, and really just being available to listen.
Great, great. Let's talk a little bit about the diverse populations that we serve of older adults. And I know that Kim Burton touched on it a little bit, but just as again, we're serving older adults, it's always my goal to meet them where they are and to have understanding about their particular backgrounds, cultures, identities. How can we ensure, especially as professionals, which there are many on this Zoom call, we are equipped, that we are culturally competent? What resources, tools, advice would you give us so that we ensure whether our, the people we're serving, they may be in rural environments like in Frederick County or urban environments like in Baltimore City, and coming from different, many language barriers or issues, gender identity issues? How can we equip ourselves? Any thoughts?
I might just kick off with the beginning of making sure that the conversation you have with that person is completely open and non-judgmental, so that they feel absolutely comfortable telling you who they consider to be their community of support. So I just want us to be mindful that we shouldn't make assumptions, and we need to ask non-judgmental questions that open conversations to find out who they connect best with. But I see that Trish has an idea.
And I would also like to include that one of the things that we do with the community health workers is to make sure that we try to choose community health workers that kind of connect with the community, have similar, they live in the community, they know the community, and that really helps with that connection as far as if there's cultural differences or other types of differences that may play a role in increasing isolation.
That's great. How can we on another topic, we mentioned that transportation is often a great barrier to for our older adults getting places, and mobility is not always reliable. I hear this a lot. Any thoughts on transportation resources? How do we create better accessibility so that our older adults can plug in now that the pandemic is definitely decreasing? People want to get out. They want to get to be a part of their faith groups and recreational groups, but transportation just always seems to be a big barrier. Any thoughts on that by the panel and how we can connect them physically?
I have a lot of thoughts on this. So I deal with this every day. I work with homebound patients or home limited patients that have a taxing effort to get out of their home and really do rely on transportation, either ambulance transport or they need wheelchair support. And I think it's important to have realistic expectations. It's very limited in terms of transportation resources in the state of Maryland. So as Kim had pointed out, it's really then I would be referring folks to MAPT or to 211 for transportation resources. And I had recently shared just yesterday with Chanel, like one of the things is that what we can do as professionals or folks that work in the community is to really advocate on behalf of our patients and our clients, because the resources in the state of Maryland are really not at par to the needs that are there for the older adults. And I had shared with Janelle that the statistic, or not the statistic, but where we're ranked as a state of Maryland. Not sure if folks know this, but just recently in April, there was an edition for the Wall Street Journal where we ranked what were the top places to retire. And not folks are sure aware, but Maryland, you may be surprised to know, we were ranked 50 out of 50. We're the worst state in the country in terms of retirement. So really, there is so much opportunity. So taking this information on, it's important for us to then take this as an opportunity. Really, we can only go forward. We clearly can't go down, but we can go forward and really advocate then for our patients.
Thank you, Marina.
And I'll put the link in the chat box in case folks, because I wanted to make sure that folks then could also see it themselves if they had questions about it.
Great. And someone put in Metro Access is a great transportation service. So thank you. So we have a couple of questions from our participants. One is, how might this discussion, we're talking about social isolation and loneliness, apply to elders who are in full-time nursing care? We haven't talked about people being in nursing homes. Any thoughts on that from the panelists?
I used to work in nursing homes, and it is very challenging for people who are in the social services department and the activities department to be able to meet the needs of all the people that are there in the nursing home. So my opinion is not to rely on the nursing home as being able to meet these needs necessarily. However, there are people in nursing homes that can serve as a bridge to the community. And I find that activity coordinators are underappreciated for their creativity and resourcefulness in connecting people with activities and organizations and other people that can bring them joy. That's the piece I wanted to say with regard to that particular question. And it's a good one because too often we think that because we're putting somebody into this congregate setting where there's lots of people and lots of activities, that they will not feel lonely. And I think all of us have had that experience of being among a lot of people, but feeling lonely. So it needs to be very tailored to that individual.
Absolutely.
And I agree with Kim, but I think what's also happened is that it's also been quite exacerbated because of COVID. And I know that the governor has said that we need to lift our visitor restrictions to these nursing homes. And I know time and time again, my families have reported to me that really the restrictions in these nursing homes and even some of the senior high rises has really caused an emotional toll because they're not getting visitors. These residents aren't. So what I've been doing is really encouraging folks to advocate and try to make their policymakers or the legislators and pushing, and also for the nursing home administrators themselves, but they are somewhat limited. But really it is a major challenge, especially right now, because there are longstanding visitation restrictions because of COVID. So it's a really good question. And I think that it's really something that should be on all of our minds in terms of advocacy for these folks.
To tag on to that with Marina, I'm remembering with Baltimore Neighbors Network when we were trying to get people to be able to make calls into nursing homes and assisted living. The amazing barrier that we found was lack of telephones that folks might have. So we really, this is problematic.
So as we are starting to wind down, our hour has gone very quickly, but there is one more question that I just want to raise, and then we'll start to wrap up. And Nikki is asking, are you aware of behavioral health programs that can help and be individualized in the community to help older adults age in place?
I think Marina and I are staring at each other through, through the Zoom. Every community has different set of services and service providers with regards to behavioral health. What I would say is that for a lot of older adults, they may not recognize behavioral health, first of all, as a term, but also to identify themselves as needing mental health support. But we all know that this is about good mental health support. So increasingly, in my opinion, the area agencies on aging are working on programming that is supportive of mental health. And but there's a long way to go actually in the development of that. So that's my first thought.
Okay, well, that's been great. And I want to thank our panelists. And as we close out, I have one final question. I want you to just give your best advice or resource that would help engage our older adults and keep them involved to combat social isolation and keep them engaged and their well-being. So what one strategy or resource or tool would you leave with our audience today?
Go first. So my recommendation is the power of listening. And I believe that was said a lot by Trish and Kim, that you don't necessarily need to always have the answer, but just being a present body and listening, it has always just impacted me. And I've been amazed by how just being a present body is so powerful there.
Thank you, Marina.
This is Tricia. I think that the primary care provider is often a great resource that we didn't maybe have 5 or 10 years ago as far as identifying isolation, and having those resources, having social workers in place and access to behavioral health. That I think a lot of, I know patients and residents and older adults are not aware of even those services. So being aware that those are up and coming and something that oftentimes is the first place to start. That primary care provider is often such a respected individual among patients and older adults, and understanding that that might be a great place to start in helping find resources for isolation and loneliness.
Thank you, Trish.
I'd like to say that we need to inform our primary care providers and even Maryland Access Point about the programs we know to exist. There are people who want to make referrals, but they can't make referrals if they don't know what's out there to refer to. So I think it's important to make sure that as we learn of supportive programs, we communicate that to the health and social service organizations that are working with older adults.
Thank you, Kim. And
I think that
you have the last word.
I was going to say the same thing, to be honest, that I think following up with people, we give them resources, and it's a difficult thing to do, to follow up with the masses, but one person at a time. We give them some phone numbers to call, and not sure if they do, it's in their hands, yes, but when somebody's so lonely, I don't know if they know their self-worth. And so I think the follow-up, we have to work on that. Following up, connecting with people, and the follow-up is something that I know in our brains with chronic care management, we're always thinking about.
Well, panel, you've given us a lot to apply to our practices and to our knowledge. And I want, on behalf of Johns Hopkins Bayview and the Call to Care program, to thank you all so much. And I turn this program back over to Chanel Whitaker, our organizer. Thank you, everyone.
Yes, and I'd like to echo my thanks also to the panel, and also to Linda Stewart. She didn't talk much about a lot that she contributes, certainly for caring for caregivers who work with our older adults. So I hope that in the back of the slides, we have contact information for the speakers. Please do reach out to them. It's important, as the speakers say, that we do make some new connections to better support the community that we serve. So thanks to everyone for participating. You will get a follow-up email. I think some might not have gotten the slides, so we'll share that again, and also the resources that were shared in the chat. Thank you again, and you all have a wonderful day, and we hope to see you again at another lunch with Lamy sometime soon. So thanks, everyone.
Thank you.